Anatomy. Well, the sciatic nerve is the largest nerve in the human body, and it belongs to the sacral plexus. Here you can see that it's formed by L4, L5, S1, S2, and S3. S4 is for the other roots of the sacral plexus, but the sciatic nerve, it has it has almost all fibers of the sacral plexus, the ramal branches of the sacral plexus. Of course, you have others, but we will focus this presentation basically on the sciatic. Here we can see the the path of the sciatic nerve, the gluteal region. Sorry, aspect of the thigh. The sciatic nerve emerges from the pelvic cavity beneath the piriformis muscle, and then goes posteriorly in the posterior aspect of the thigh until it branches in two terminal branches, the tibial nerve and common peroneal nerve. This level of branching or division is variable, but in major part of the patients, it occurs around 10 centimeters of the popliteal fossa crest. I mean, this can happen here or here, but normally it happens more distally. Okay. This is the sensitive, cutaneous sensitive area of the sciatic nerve, and mainly we have this cutaneous innervation that it blocks it beneath the knee level. Then we have especially the posterior aspect of the calf, the foot, and fingers. And here in the medial aspect of the calf, we have this influence of the saphenous nerve. But in 15% of the cases, the sciatic can innervate the calf and then foot and ankle and feet alone. I mean, there is this variation in which the sciatic nerve can be responsible for all innervation below the knee, which is not so frequent. It's 15%, but it can happen. Here we can see the many approaches that we have for the sciatic nerve block, and we have the deeper ones, the posterior, the gluteal, let's say a posterior approach. Here we have the anterior one. You see that we use here long needles, like 10 centimeters needles, and curved transducers because of the here we have some more superficial approaches like lateral popliteal, like subgluteal, infragluteal. I mean, we have different ways of different levels, I mean, to approach the sciatic nerve. We can do it either proximally, especially for hip surgery, or distally for surgeries involving the knee or below the knee level. And here, in this superficial approaches, more superficial approaches, we can use the linear transducer with high resolution ultrasound. I will present you now the gluteal approach. As we can see here, we use a curved transducer. We have a long needle, I mean 10 centimeter needle, and the patient is in Sims position where we can use the bones like landmarks, like the greater trochanter and the ischial tuberosity that we can see here. Well, we see that the bone structures are important landmarks. Here we see the femur, and we see the ischial tuberosity. We have muscles here. This is gluteal maximus muscle, and we have other muscles like quadratus femoris. And the important thing is that the sciatic nerve is in between the bone structures, and in order for us to depict the nerve correctly, we have to have a contrast between the predominantly hyperechoic image of the sciatic nerve, which is this one here, It's like a flat or lip-shaped structure. And the muscles, which are hypoechoic. Okay, this is a very superficial image of the sciatic nerve because normally the nerve is deeper. It's like 5 to 6 centimeters. Here is like 3.5 centimeters, which makes it easier for us to depict the nerve. But it's not always like this. Here we have a cross-sectional image to illustrate the same approach. And here we have the femur bone. We have the ischium bone as well. And we have the gluteus maximus and the muscles beneath, like the quadratus femoris. And here we have the sciatic nerve. You see, like there is a compartment here fulfilled with fat, but here we have the sciatic. This is another image of the gluteal approach, in which we have, once again, a very thin patient. This is something like 4 centimeters deep, and the sciatic is this image here, predominantly hyperechoic, flattened image, lip-shaped, and there's a fascicular pattern, but it's difficult to image this fascicular pattern. And we have the quadratus femoris muscle behind the nerve, which is anterior. This is posterior, and this is gluteus maximus muscle. But of course, the most important structures are the bones. The special landmarks that we have here are the bones. The greater trochanter and its acoustic shadow, and the ischial tuberosity and its acoustic shadow. Okay. This is an image of the anterior approach, which you can see it's performed in the proximal and medial aspect of the thigh. And we have, once again, a bone structure as a very important sonanatomic landmark for this procedure. We have femoral artery here. We have the femur bone and its acoustic shadow. We have the anterior muscles like adductor longus, adductor brevis, and pectineus and adductor maximus, anterior muscles, and posterior to them, there's the gluteus here. This is posterior, this is anterior. And the sciatic nerve is this, again, this predominantly hyperechoic structure with this lip shape, I mean, very flattened. Okay. And this is, I can go too fast. And this is the anterior approach, in which we can see the muscles, I mean, the adductor muscles and pectineus. And we can see here the sciatic nerve in this depth. This is the average depth in which the sciatic nerve is located by this approach is around 5 to 6 centimeters. Okay. This is a subgluteal. It's slightly below the gluteus muscle, I mean the gluteal region, and we see the nerve a little bit more superficial, and this is the predominantly hyperechoic muscle, predominantly hyperechoic structure, flattened, and the contrast between the sciatic nerve, which is predominantly hyperechoic, and the muscles, hypoechoic, which this is what makes it possible for us to depict the sciatic nerve. But here you can see we use linear transducer, which makes the resolution much better and makes it easier to identify the nerve. This is another image at the same level. We can see very well the needle because, of course, we have a flattened angle of insertion of the needle. The nerve in its fascicular pattern, it can see very well here. The definition is much better, the resolution. And here we have the anterior sciatic artery, which follows or accompanies the nerve throughout its course in the posterior aspect of the thigh. It's important that at this level we have laterally the bicep femur, the semitendinous and semimembranous muscles. This is posterior, and this is anterior, and this is adductor muscle maximus, posterior to the nerve. Okay, and this is what we have. We have the predominantly hyperechoic nerve surrounded by muscles, especially, and this contrast makes possible the depiction of the nerve. Popliteal approach can be done in many ways, but these are the two most common techniques: the posterior one, which is the classic one, and the lateral one. Well, depending on the positioning of the patient, I mean, sometimes you have this lumbar fracture, you don't want to change the patient's decubitus or position. You can keep the patient at this situation without changing and perform the block, or it goes the same for anterior approach, the proximal that we have mentioned before. I mean, when you cannot put the patient in prone position for a special reason, this is a very useful technique. But at the same time, this is a very useful technique for practice aspects. I mean, for practical aspects, because here you do not have to change the patient positioning. Then it's faster to perform the block, especially when you combine the sciatic nerve block with, for example, adductor channel block or Stephanos block. You have to perform two, and if you have to turn the patient and then turn back the patient, this it's very time consuming. This is a very nice approach in which you don't have to change the patient position, and you have, let's say, a shorter time for performance. This is a very interesting study that tried to establish the correspondence or correlation among ultrasound, the cross-sectional anatomy, and the histology, to try to demonstrate that images that we see depicted here with ultrasound correspond to the what actually we have in the human body. I mean, this is the gluteal image. This is a thin patient. That's why they're using this linear transducer. Here we have the cross-sectional image. You have the gluteal muscle here. We have some kind of veins or vessels here. You have the nerve, and we have bones here. This is the femur. Okay. And here we have the histology, in which you can confirm these are different tissues. This is muscle. Here we have nerve. Here we have bones. Okay, femoral head, and this is very interesting for us to establish this relationship. Here we are at the subgluteal or infragluteal level, in which you can see again. This is cross-sectional. We can see muscle. We can see the structure of the sciatic nerve here, and it's interesting to understand that this is completely different from this what we see with the ultrasound image. In the ultrasound image, as this contrast, and here at the histology, we see again these are completely different tissues. This is the sciatic nerve, and surrounded by muscles. And around there's a very thin layer here around the nerve, which is not the epineuron, which contains some fat and small vessels. Now here we are at the popliteal level, and here we can distinguish a very important aspect of the sciatic nerve at this level, is that here the nerve tends to be round, and of course here there's already branches in that it's two terminal branches, the comoperoneal and the tibial nerve, as we can see here in the cross-sectional. They are divided, but interestingly we can start to depict an external layer, facial layer, surrounding the nerve, which is not the epineuron, and which is called by many the paraneural fascia surrounding the nerve, which isolate the nerve from the muscles. And this is confirmed here, the two nerves and muscles and this different or compartment that we have here. Well, I'm not going to talk about differences or advantages regarding ultrasound in comparison with nerve stimulation a lot. I'm just going to talk about this specific aspect. We all know it's after 15 years we've been seeing that, of course, it's faster onset, it's faster the performance timing, it's faster, and the many other aspects in which ultrasound has advantages over nerve stimulation. But I try to show in a specific detail the volume. And as we can see here, if we are searching for an effective doses for 95% of the patients, we require the ultrasound technique, specifically in the subgluteal approach using mepivacaine 0.5, requires half the volume that the nerve stimulation requires. Sorry, this is Portuguese, I forgot to change. And then what we have here is that if we want to perform a sciatic nerve block, it's interesting to use ultrasound not only by the other aspects of time of performance, easiness and comfort and things like this, and onset, but especially because we are allowed it to, or we are enabled, they're saying, to use lower volumes, half the volume. And this is very important because normally we combine sciatic nerve with the lumbar plexus blocks like femoral or saphenous or whatever, and this makes the amount of a very large amount of local ones we have to consider in order to keep, say, the safety of the block. I mean, toxicity and things like this. Then, if we are able to diminish our volume in half, it's a very interesting thing to. It's very interesting thing that we should pay attention to. Well, many of you are thinking right now as what is the decision that we should take? I mean, if we want to choose by anterior or posterior techniques to approach the sciatic nerve, what is the best approach? Both are deep and both are proximal for hip indications, like hip procedure indications. And this group here did this study to try to understand if there was an advantage to perform an anterior approach over a posterior approach. And what they found is that there is no difference. I mean, the complete sensitive block in 30 minutes, as well as the complete motor block in 30 minutes, they are not different, significantly different. Then you are free to perform which one you are more used to, but there is no advantage over one technique to another. Well, this is a very interesting study conducted by Dr. Chan, and he tried to validate, and he did, the correlation between the positive identification with the nerve and its depth, which means, in other words, the identification that they had of the sciatic nerve at the gluteal level, which is a deep level, in comparison to other regions, subgluteal or proximal type, was different. I mean, in 100% of the cases, the superficial regions made possible to depict the nerve clearly, and the gluteal, the deeper one, it was possible only in 87% of the cases. And this validates the correlation that we already had in mind that the greater depth, the worse resolution. And of course, if we are talking about a technique based on image, the quality of the image is very important for us to succeed. I mean, if we have a worse, I mean, if we have a poor quality image, we'll probably have more difficulties to perform the block, or even we have safety issues with performing the block. It's not just success that we are dealing with here. We are dealing with safety as well. And this is a study that may exemplify this very well. This study here, it's a prospective study in which they could identify unintentional intraneural injection around 16.3% ultrasound guided subgluteal approach. Well, as I was saying before, if we have poor images of the nerve, we can have poor image of the local anesthetic spread, or we don't know exactly what are the borders of the nerve and its interaction with the needle tip, and we can have unintentional intraneural injections. Then, if we are performing deep blocks or the sciatic proximal blocks, we should have a good reason to do this. Because if there is not for a hip procedure, there is no reason to choose a proximal approach over a distal approach, more superficial, where we can easily depict the nerve and easily image the needle tip. And this is the image of a normal sciatic at subgluteal level, the lip shape, fascicular, and we have here the paraneural fascia and the local anesthetic, this hypoechoic around the nerve. This is what we desire to see. This is the ideal, and this is what we don't want to see. This is the same approach. I mean, the same level, and that what we see here is a round nerve, which was supposed to be flattened, and we see this dark area and this swollen nerve. Then what we have here is that the local anesthetic was injected just inside the nerve. There's much this knowledge about the paraneural fascia. This paraneural fascia is been done for a long time by Sciatic and Bloqueo. They studied this with microscopy and this cross-sectional, and they could see that there was this external layer of fascia surrounding the nerve. Okay, and then this is epineuron, right? And there is an extra layer, an external one, surrounding the nerve. This anatomical aspect, this layer, was detailed. It was studied in more detail and more recently by Dr. Kamakar with a high-definition ultrasound to define exactly this paraneural sheath and the facial compartment surrounding the sciatic nerve at the popliteal fossa. What we see here is that we can depict clearly that there is this external layer surrounding the two. We have local anesthetic here, and sometimes the sciatic artery is still here, and this is very important, very, very important for two aspects: for onset and for safety and effectiveness. Three aspects, sorry. Then what we have here is that if you want to succeed in a sciatic nerve block, you should deposit the local anesthetic within or beneath the paraneural sheath. If you do this outside, there will be a block failure or a long onset, like 1 hour, or even a failure, a complete failure. If you understand that this is a sheath and the nerves are already divided, you can perform just one puncture side injection, and you can surround both terminal branches without the need or without having the needle many times, avoiding problems like neurological deficits or vascular punctures. You can just insert the needle in between them, just piercing the paraneural sheath, and it will be done. Just one site to access and inject, and it will be done. Okay? And if we have both of them divided, it's going to be much easier to do this in comparison to if we do this more proximally, where the nerve is still just only one trunk, and we don't have a very well-defined place to insert the needle safely without piercing the nerve. Regarding onset, Dr. Moreau and Capdevila in their group, they did a very, very interesting study that showed us that if we decide to perform the block at the popliteal level and we deposit the local anesthetic surrounding both terminal branches, we would have a faster onset in comparison if we do this in the nerve, surrounding the nerve as a trunk. The basics for this understanding is that the sciatic nerve is a very thick nerve and with a great diameter, and then the anesthetic diffusion to the core aspect of the nerve, it takes long, and this is it's a problem in the clinical practice, because the onset it's not as fast or short as for upper limb blocks. Then, if you perform the block after its branching, you will have a shorter onset, because the diameters of the terminal branches itself are smaller than the trunk, the major sciatic trunk before its branch. Well, talking again about onset, this is a very recent study. This is this month, Regional Anesthesia and Pain Medicine, in which this Italian group performed intraneural injections, 20 ml of ropivacaine, in comparison to subparaneural, and they managed to demonstrate that significantly the intraneural injection reduced the onset. But of course, there was a lot of criticisms over it, and we can address this later. In my opinion, I already said, it's dangerous and there is no justification for doing this. Well, let's go to the pearls. Ultrasound guided sciatic nerve block is easier and possibly safer to perform, utilizing superficial approach. Let's keep it simple. Why do we have to make it more complex than we need to do it? I mean, if you are indicating the sciatic nerve block for foot and ankle or even knee surgeries, why do we have to do this at the proximal level, where the needle image is poor and the nerve image is poor as well? We can have better images and faster times to perform the block, and even more safety if we perform it more distally. Well, the second one is already, I've already said, the popliteal approaches are useful to most sciatic nerve block indication except hip procedures. Popliteal approach presents shorter onset times in comparison to proximal approach, and offer an easier paraneural site of access because of its anatomical aspects of division, and we can depict clearly the paraneural sheath and exactly spot to pierce the facial layer. And Finally, despite inconclusive data regarding safety of the sciatic nerve intraneural injections, this practice should not be encouraged because no diminished onset justifies the risk. Thank you very much, and if you have questions, I'll be glad to answer them one by one.
Bye, thank you.
Thank you.